Welcome to Diagnostic Imaging's weekly scan. I'm Whitney Palmer, Senior Editor. We're here with you again this week with the latest updates on the COVID-19 outbreak and its impact on the radiology industry. To date, the neurological manifestations of COVID-19 in pediatric patients have not been extensively reported. However, this week in the journal Radiology, researchers from Iran published a case of pediatric stroke related to the virus. With this case, a previously healthy 12-year-old boy was admitted to the hospital with seizures but no other symptoms. Tests ruled out herpes simplex 1 and 2 infections, as well as varicella zoster virus, and no one else in his family had a history of COVID-19 infection. While an RT-PCR test came back positive, low-dose CT, carotid color Doppler ultrasound, and echocardiography came back normal. MRI images, however, indicated stroke. The child was eventually discharged to home, but right-sided paralysis remained. As the pandemic continues, the role of lung ultrasound is still emerging, particularly with pregnant women who test positive for the virus. In a study published in the Journal of Ultrasound in Medicine, investigators from Turkey presented findings that showed lung ultrasound can prompt or change treatment practices in this patient population. In a study of 8 pregnant women, 87%, had their doctor change their medication after seeing the lung ultrasound findings. The research team determined lung ultrasound is best used under 3 circumstances: with asymptomatic patients who are positive for the virus, but for whom CT has not been planned, patients with mild symptoms who do not give consent for chest CT, and ultrasound surveillance of an asymptomatic patient with negative CT findings, or follow-up of treatment response in symptomatic patients. Much attention has been paid throughout the pandemic to chest CT and chest X-ray scans. However, other imaging modalities and tools are also playing a role in assessing patients, and radiologists may need to know which modalities will work best in particular situations. In the journal Radiology Cardiothoracic Imaging, researchers from Icahn School of Medicine at Mount Sinai outlined the uses, benefits, and limitations of chest CT, X-ray, MRI, PET-CT, chest ultrasound, echocardiography, and artificial intelligence tools in managing viral infection. As imaging services continue to open up, being able to identify which patients need scans most urgently will be critical. To help interventional radiologists most effectively triage patients, a multi-academic medical center team led by the University of California, Davis created a 5-tier system in the American Journal of Röntgenology to help radiologists categorize patients. They recommended providers triage patients based on urgent procedures, procedures that should be performed within 2 weeks, those that can be performed within 2 months, services that can be delayed for 2 months, and procedures that can be delayed for 6 months. Heart researchers also shared news this week that could change how doctors assess a patient's risk for developing coronary heart disease and experiencing a heart attack or dying. In a study published in JAMA Cardiology, investigators determined pairing coronary computed tomography angiography with exercise electroechocardiography can provide a more accurate 5-year assessment. By evaluating medical data from 3,283 patients, the team determined abnormal exercise ECG results were associated with a 14.5-fold increase in coronary revascularization within 1 year of evaluation, and a 2.6 increase in experiencing a non-fatal heart attack or dying within 5 years. But coronary CTA is associated with improved prognostic discrimination, they said, because patients with obstructive coronary artery disease had a 10.6-fold increase for negative outcomes within 5 years. Whether you work in an academic department, a private practice, or in an imaging center, there's a high likelihood that you are now familiar with working remotely. And for many of you, this might be your first foray into remote interactivity. Doing so can present challenges and opportunities both for career providers and trainees. This week, Diagnostic Imaging spoke with Dr. Matthew Barkovich, Assistant Professor in Residence and a neuroradiologist at the University of California at San Francisco, about how the department designed and implemented its remote interactivity structure, the challenges they faced, and the solutions they designed. Here's what he had to say. Welcome to Diagnostic Imaging. I'm Senior Editor Whitney Palmer. Today, we are joined by Dr. Matthew Barkovich, Assistant Professor in Residence in the Department of Radiology and Biomedical Imaging at the University of California at San Francisco. Thank you so much for joining us today, Dr. Barkovich, to discuss how your department has encouraged and facilitated remote interactivity with your faculty, residents, and trainees. We appreciate your time.
Thank you for having me. It's good to be here.
Wonderful. Well, thank you again. Well, to jump in, what steps did UCSF take to ensure and maximize the social distancing efforts?
Well, I think initially off the bat, we were really trying to reduce the traffic in the reading room, which traditionally at our hospital has been kind of a hub of activity for clinicians to come and discuss things with us in person. And so it was a cultural shift to close the reading room, try to compartmentalize faculty and learners so that there was just less interaction of a larger group of people. So we have three main different sites that our members of our department go to. And during the initial COVID run-up, we kept trainees and faculty at one of those sites. So we cohorted our faculty. And in addition, we tried to spread out our reading room environments. So we repurposed some areas that were not traditionally used for interpretation in order to have more areas for people to read, where potentially you would be in a room with fewer people or further away from the people who you might normally be sitting side by side with.
All right. So, with those efforts in place, what kind of role did video conferencing take, and at what point was that introduced to maximize both productivity and social distancing for safety?
So that really started taking place once we saw that we were having trainees who were maybe not in the same room as a faculty, or maybe not even in the same site as a faculty. And traditionally, that was something that was infrequent. It was something that we tried to avoid pre-COVID. And as a result, we would just do phone readout in the rare instances where that would happen. But when that's a more day-to-day environment, that's clearly not optimal for learning. And it's not really optimal for even just interpreting images to have two people kind of looking at different screens. And so we had been using the teleconferencing software for conferences, for lectures, even prior to COVID. So it was something we were familiar with. It was something that we already had deployed on our PACS workstations. And so that was kind of the next step. Obviously, when possible and when safe, I think our trainees and we as faculty still prefer being at least in the same room as the trainee, but sometimes that's not possible, sometimes that's not safe. And so I think that both us and the trainees prefer the teleconferencing approach to a phone readout when a face-to-face readout isn't possible.
And that is certainly understandable. What about for those faculty, though, who may not have been quite as familiar with the technologies? Was there any kind of training or extra guidance that needed to take place to kind of get those individuals up and running?
Yeah, I think that was definitely an issue, both on the conference side and then on the more day-to-day workflow side. So we actually have somebody in the department whose job it was prior to COVID to coordinate the teleconferencing for multidisciplinary conferences. Again, we're spread out across multiple sites, so that was something we had pre-existing, and so he's been really invaluable in terms of preparing resources for our particular vendor that we are emailed out. We have had training sessions for people who are interested. I think there've been almost a dozen different individual training sessions held via Zoom for faculty who didn't feel familiar, or trainees as well who didn't feel familiar. So we were fortunate to have someone who already was in a similar role, who was able to expand his scope to the other areas that we're using teleconferencing software for now.
Gotcha. All right. Well, then turning from the technological details and thinking more about the educational aspects of this, how did implementing more video conferencing and teleconferencing affect the education for residents and trainees?
Well, that's a really good question, and I think it's hard to sort of tease out. There are so many things that this pandemic has changed in terms of our volume, in terms of the normal learning environment, that it's kind of difficult to tease apart, what was the drop in case volume versus what was the difference in the readout reading room experience. I think that one of the things that I have heard is it's more challenging. When you're face to face, it's easier to have a little bit more of a back and forth. There are natural pauses that are easier to step into. And so I think remote readout, it's tough for people to stop and ask questions. It was tough initially for, one person will have control of the screen and the other person will be watching. But then we discovered that our vendor actually allows you to share control of the screen. So if you don't know, and I'm sure other vendors do this as well, but in Zoom, with Zoom, you can share control of your screen, which means that if the attending radiologist is controlling and scrolling and the trainee has a question, they can ask for control of the screen. Then they can use the mouse to point and scroll to whatever was an area of concern, which, normally when you're reading out over the phone, you're talking about image numbers, you're talking about series numbers, and even then on a single image, if somebody doesn't see the same thing as the other person does, it can be really tough. And then with this software, again, that's the same as what we had side by side. I think that part of teaching is the human interaction, and we've all been adjusting to having less of that. And I think that's been challenging as well. But I think, within the limitations that we have in this current environment, I think those are all challenges that can be worked around. Does that answer your question?
Absolutely. And I'll circle back around to challenges in just a moment, but I did want to follow up as far as the remote readouts and the remote consultations are concerned. How are those working in this environment? Can you kind of give us a nuts and bolts step-by-step of how those are occurring on the daily basis?
So I think I'll attack the remote consultations first and then move on to remote readouts, because I think the remote consultations are more challenging because it involves, we've built relationships as radiologists with our clinical colleagues, and a lot of those relationships involve us knowing our colleagues personally, and so spreading the word that we're kind of closing down the face-to-face shop can be a little bit difficult. And I mean, people understand, but I think that that the sort of relationship-based change, it can be challenging. Fortunately, we have good interactions with our colleagues, so we're just able to reach out to the major departments, particularly our infectious disease colleagues would make visiting us a part of their normal working day. And so instead we have scheduled, they will reach out to us with a list of cases they want to review. We'll schedule a time where one of our fellows will start a Zoom meeting and review those cases. And in some ways it's actually been an improvement, because as opposed to in the normal workflow where someone will just come into the reading room and you may be in the middle of something else and you haven't had time perhaps to review these cases, here it can occur at a scheduled time and you have a chance to review the imaging prior to discussing it. So in that regard, it's actually been an improvement. It kind of takes an interruption and allows it to be a little bit more of a scheduled activity. And then your second part of your question was the trainee part of the remote readout.
Okay.
So for us, each faculty is usually responsible for a handful of trainees, maybe 1 to 4, depending on the site. And so it's really been just like our fellows did previously. They'll accumulate cases and let us know when they're ready to read out. That usually still occurs via phone. Just we don't have a Zoom line open all the time. And then the attending will start a Zoom meeting that the resident or fellow can join with the cases that are loaded up. Again, we have a common work list, at least for the neuroradiology section that I'm a part of at UCSF. And so I can look and see the cases that the fellow or the resident who I'm working with has claimed, and bring those up, so that that doesn't require any additional back and forth. It's really just a matter of creating the meeting, inviting the resident to the meeting, and then from that point forward, other than that, we're not physically side by side, it proceeds in a fairly straightforward manner. We have the same, we're viewing the same thing, we're able to communicate verbally, so you just take it from there.
Gotcha. Well, then when it comes to some of the challenges that you mentioned already, are there additional ones that you have not touched on? And then, and on the flip side of that, or in continuation of that, how have those challenges been addressed to make things run as smoothly as possible as you've gone through the pandemic?
Well, I think initially that we had, like many people, some issues with potential security risks, with just setting up software for people who aren't familiar with it. The familiarity thing I think I touched on earlier with having departmental trainings. Security, again, your vendor may vary, but our instance of Zoom is HIPAA compliant. And then with some of the concerns of Zoom bombing and whatnot, we've enabled additional security features. What we recommend that people do is, after you have your trainee join the meeting, you block further participants from joining. I mean, it's not always easy to remember, but really, for when you're dealing with PHI, that's probably the most secure thing to do. At the very least, we have by default, you can set it up so that you have a waiting room enabled, which means that a lot of those advanced features like screen sharing, like screen annotation, those things are only available to meetings that you let in, to meeting participants that you let into the meeting room, as opposed to those who are sort of walled off in the waiting room. That also has been helpful for multidisciplinary conferences. Because whenever you take something sensitive like our imaging data and you put it online, you want to make sure that you're using a secure resource. You want to make sure that you're not leaking PHI, that you aren't opening yourself up to all of the dangers and whatnot that's associated with that. Trainee isolation and faculty isolation too. That is a big issue. Because here people are isolated at home, people are isolated at work for good reason, but it's challenging, I think, to maintain a sense of camaraderie during times like this, when you aren't seeing your technologists, when you aren't seeing your nurses, when you aren't seeing your colleagues in the hospital. And for that, I think we've just tried to keep our social distance communications open. We've tried to, I know I've reached out more to our trainees who are taking call, for example, just to let them know, when they do a good job, that there is still somebody there, somebody who cares and is paying attention. And then I think those are really the major challenges, are just kind of born of this very challenging and difficult time. But I think our trainees have, to the extent possible, been maximizing their learning opportunities, trying to make up for that diminished clinical volume. And they've really been eager to learn. They've been incredible through this. So.
That's wonderful. Continue on along that thought. Are there certain aspects of trainee education that have best translated to video conferencing? Maybe ones that just seem to be better suited for doing this type of instruction. And on the flip side of that, are there ones that have been a little more difficult to incorporate into a remote interactivity type of environment?
I'll start with difficulties. I think that there's a certain element of just being able to pull something, pull up either a physical book or something on your laptop and show it to somebody during readout. the sort of back and forth, being able to incorporate other people in the reading room into the conversation, because it's a big group. That is challenging to extend. I think the consulting one of your colleagues or showing an interesting teaching case to another trainee who's in the room, that's more challenging to do. You have to make a more active effort than just sort of to speak up, raise your hand and say, hey, I have an interesting case here. So that I think has been one of the bigger challenges of translation. But again, those rooms can allow multiple people. So you can invite another trainee to the reading room, to your virtual reading room. You can invite a medical student, because unfortunately our rotating medical students aren't allowed in the reading room at this time. So they're learning from home. You can invite them to the readout. You can invite one of your faculty colleagues to the readout. So it's possible. It just takes a little bit more work than maybe it did when everybody was in the same room. I think in terms of benefits, the virtual readout, you have annotation software. You can allow both people to have control of the mouse. Normally, when I'm sitting at the workstation, I have the mouse, I have the keyboard, I have control. It might be a little bit more challenging, to hand it off, look at things separately. There's no annotation features in our normal PACS workstations, so the trainee can't circle something on the screen or mark it up beyond the annotation features that are built into the PACS, of course. So I think that is an improvement. But ultimately, I do think that while virtual readout with a teleconferencing software is superior to other forms of remote readout, it's still, and this may be in part just our lack of experience with it, but I don't think that it is, from a trainee or a faculty perspective, better than what we had face-to-face. But I do think it's the closest approximation that we can at least come up with during these challenging times.
Well, that dovetails into my next question as far as feedback is concerned. What's been the response between the faculty and residents and trainees to having to work this way on a relatively short notice, really?
I mean, I think we all understand the reasoning behind it. That being said, and I think that the feedback that I've received is that it's definitely better than the alternatives. But in reading room environments where it's possible to maintain social distancing and also still have a degree of, maybe not face-to-face, but at least a fingertip to fingertip interaction, that is probably still preferred. I think the other factor that I hadn't really gotten into yet was that it depends on the level of experience of the trainee. Our fellows are able, because they're just, they've already had 4 or 5 years of training. They're just much more easily able to adapt to these different types of teaching than, for example, our junior residents who are outstanding, but still, I think the face-to-face interaction gets you a lot more in that earlier set of training. And so I think that it's a little bit more challenging for them. And to the extent possible, I try to see if we can get them to maybe be in the same physical location as us, whereas maybe our more senior residents and fellows would be people who'd be better to have a little bit of distance with, just because they can still get the same learning experience without necessarily the physical presence.
Well, given that there might still be some institutions that have not delved into the concept of remote interactivity quite as much, or maybe there are some who are trying to improve what they are doing, what type of advice or guidance would you provide on how they can kind of take steps in a direction to either improve their activities or get started on the right path?
Well, that's another great point / question. I think that it really, from the technological side, there are kind of a couple of branch points. We have PACS workstations that have a limited internet access, which makes using sort of out-of-the-box teleconferencing software easier at our institution. We also have a site-wide instance of a teleconferencing provider that's HIPAA compliant. So if you have those two things, deploying your existing teleconference software on your PACS workstation may be something that is relatively more easy from a technical standpoint. If, on the other hand, you have a PACS workstation that is not internet connected, if it's just on an intranet, then using an out-of-the-box teleconferencing service on it is much more involved. Some of our sort of associated sites have that set up, as opposed to what we have at UCSF, where they're internet connected. And that means that you have to decide, are you going to use something like Zoom or Microsoft Teams, or if so, you'll need to involve your IT department. I would argue that our experience, at least, has been that the productivity improvements that you get from having internet connected PACS would make it worth it. But that was a long process for us in our department to get the internet capability on PACS in a safe and HIPAA compliant manner. So that may not be something that is immediately available to some institutions, in which case you can have a sort of a improved trainee experience that might somewhat complicate the diagnostic workflow. That is to say, reviewing the images on a like a hospital computer, basically a non-diagnostic workstation with the trainee, and then doing a second review on a diagnostic workstation. I know that some of my colleagues who are affiliated sites where they don't have the internet capability on the PACS have done that, but it does mean that you don't have the benefit of a diagnostic compliant monitor, and you, for purposes of final interpretation, would need to re-review the images or preview the images prior to or after readout. So those are the real technical limitations to this. There are also, again, vendor agnostic, but there are certain vendors who have remote interactivity built into their remote viewers. I know that we have that. The issue that we've encountered there, and the reason that we favor, at least in our section, Zoom a little bit, is because most of those don't have audio conferencing capabilities built in. It's essentially screen sharing and mouse sharing. And so that gives you some of what you need, but you still are having to have a phone call. But these are options. So I think my advice would be, first, assess what your capabilities are in terms of remote screen sharing and or cursor/image sharing on your existing PACS setup. If you have something built in, maybe a phone call on top of that might be your easiest deployment. If you have something like that will get you on the ground soonest. Then, if you don't have that, or if you use that and don't think that it's really the best solution for your institution, that's when you need to start looking into what sort of teleconferencing software do you have at your institution. Is it possible to deploy it on your PACS workstation? And again, that's going to be very, very site and department specific. But it's certainly possible. I know that we're not the only, UCSF is certainly not the only place that does have internet capable PACS. So I think it will depend on, again, it depends on a lot of things.
All right. Well, perfect. Well, Dr. Barkovich, I appreciate this. Last quick, I guess, overview question. Is there anything that we haven't discussed about remote interactivity and the benefits or the challenges of it as we continue to go through the pandemic?
I think that our chair has, Chris Hess has a really, measured and I think, reasonable approach to this sort of thing, which is that through, no matter how dark and how disruptive and how crazy everything is, change will always bring with it the opportunity for a positive improvement. And so I think when we're confronted with challenges, I know sometimes I can find it difficult to see the positive, but I think that we are finding that technology that we had previously can be used for so many different things and for different things that we hadn't even imagined. We had applications we hadn't even thought of possible before. And so in these challenging times, finding perhaps that there are things that we could do better, that's a great opportunity for improvement. And remote interactivity, I think, is just going to be one of those things. I think that there will be good that will come of this as well. So thank you.
Wonderful. Well, Dr. Barkovich, I appreciate your taking the time. Thank you so very, very much.
No, thank you. Thank you. It's been wonderful.